Welcome to The Explainer. Today, we're diving into something that's an absolute cornerstone of surgical safety, perioperative antimicrobial prophylaxis. We're going to get really specific, focusing on two incredibly high-stakes environments, standard cardiac surgery and the implementation of left ventricular assist devices, or LVADs.
You know, this quote really just hits the nail on the head, doesn't it? It perfectly distills this fundamental principle of modern surgery. That single, perfectly timed gram of cefazolin isn't just some routine step we go through. It's a powerful, evidence-based strategy that very often is the only thing standing between a brilliant outcome and a truly devastating complication.
So, to really appreciate the power of this shield, we first have to understand the threat. Let's clearly define the problem we are working so hard to prevent in the first place.
The main adversary here is the surgical site infection, or SSI. Make no mistake, this is a massive driver of patient morbidity and, in the worst cases, mortality. But beyond the terrible cost to the patient, these infections are also a huge and largely preventable drain on our clinical and economic resources.
Now, effective prophylaxis isn't about just carpet bombing the patient with broad-spectrum antibiotics. No, it's about precision. It's like a sniper mission. And that means the first step is always to identify our most likely microbial adversaries.
And this is where that surgical precision really comes into focus. For most standard cardiac surgeries, our strategy is laser-focused on one main culprit, Staphylococcus aureus. But when we're talking about a complex LVAD implantation, the battlefield changes. The list of potential pathogens widens significantly, and we've got to be ready for Staphylococci, sure, but also gram-negatives like Enterobacteriaceae and even Enterococci.
Okay, so once we know the threat profile, we can select the right shield. Let's take a look at the specific, tailored prophylactic regimens for each of these scenarios.
And the tailored approach is just crystal clear here. For standard cardiac surgery, cefazolin is our workhorse. It does a fantastic job targeting S. aureus. But for the high-stakes LVAD procedure, we have to escalate. We bring in the big guns, a powerful combination of vancomycin for broad gram-positive coverage, and that includes MRSA, plus gentamicin to handle the gram-negative threats. And notice this is crucial. The vancomycin has a dual delivery. It goes in intravenously, yes, but also directly into the heart-lung machine prime. That's how we maximize its concentration right where we need it most, at the surgical site.
But here's the thing. Choosing the right drug is only half the battle. If your timing is off, you might as well not have bothered. To be effective, the timing of administration is, and I mean this, absolutely critical. You have to get that shield in place before the first moment of risk.
The entire goal of this clock is to make sure that antibiotic levels in the tissue are way above the minimum inhibitory concentration, the MIC, for our target pathogens, right at the moment of incision. So for standard agents like cefazolin, we give them within 60 minutes of that cut. But for drugs with a longer infusion time, like vancomycin, you have to start a full 120 minutes prior. And our vigilance doesn't stop there. We have clear rules for redosing during long surgeries to keep those drug levels right where they need to be.
You know, a truly robust prophylaxis strategy doesn't start when the patient enters the operating room. Not at all. It begins long before that. We have to identify and mitigate patient-specific risks to head off those devastating complications.
Just consider the power of this single proactive step. A huge portion of the population carries Staphylococcus aureus in their nasal passages. It's a major endogenous source for postoperative infections. But by simply screening our patients and using a preoperative nasal decolonization protocol, we can slash the risk of a post-op S. aureus infection by a staggering 60%. That is a massive win. And this just hammers home the need for a holistic patient assessment. Factors like obesity, uncontrolled diabetes, smoking, poor kidney function, they all dramatically increase the risk of a deep sternal wound infection, or DSWI, which is honestly one of the most feared complications in cardiac surgery. This means our prevention strategy has to extend far beyond the pharmacy.
All right, theory is one thing. Let's put these principles into practice. We're going to run through a few clinical scenarios just to synthesize all this knowledge.
Okay, first up, a patient is scheduled for an LVAD implantation.
Based on everything we've just covered, what's the precise prophylactic protocol you're going to initiate?
That's it. It's the dual-agent therapy. It kicks off with vancomycin, both intravenously and in the pump prime, and it's paired with that single pre-op dose of gentamicin. This whole combination is specifically designed to cover that much broader spectrum of pathogens we anticipate in these complex, high-risk patients. And of course, getting an infectious disease specialist involved is always a prudent move.
Next question. Let's go back to the foundational principles of administration. What are the absolute golden rules that govern the timing and the redosing of these agents?
The core principle, the #1 rule, is administration within that 60-minute pre-incision window. Now, while a single dose is often enough, you absolutely have to redose if certain triggers pop up. Think of them as red flags. If the surgery runs longer than 4 hours, or about 2 half-lives of the drug, you redose. If there's significant blood loss, you redose. Why? Because you are literally washing the antibiotic out of the patient's system, and drug levels could drop below that critical therapeutic level.
And for our final case, you've got a patient coming in for cardiac surgery who you know is an S. aureus carrier. We know the antibiotic plan, but what are the other non-antibiotic risk factors for a deep sternal wound infection that you need to be on high alert for?
Your first and most direct move is preoperative nasal decolonization. That's step 1. But you cannot stop there. You also have to account for all the other compounding threats. Comorbidities like obesity, diabetes, and peripheral vascular disease are like risk multipliers. They significantly heighten the patient's overall risk profile. So aggressively managing those conditions is just as critical to preventing infection as giving the right antibiotic.
So the principles we've laid out today are based on the microbial landscape we see right now. But pathogens are smart. They evolve, and antimicrobial resistance is an ever-growing, ever-present threat. And that leaves us with a really vital question to think about. As our enemy changes, how must our evidence-based prophylactic strategies adapt right along with them to protect the patients of tomorrow?